Hello, welcome back to part two of our board meeting for NHS West Yorkshire Integrated Care Board. We're here in Wakefield today. Around the table we have representatives from health and care across our West Yorkshire healthcare system. Hello, my name's Cathy Elliott and I am Chair of NHS West Yorkshire. We now are on item 15 of our board agenda, and if you're interested in following the meeting, whether you're watching live here in the room or on the live stream or on record afterwards, all the reports for this meeting are available on our website, and the documents are always published 1 week in advance of our meetings. So the next item we have is our board assurance framework, and for those that are not so familiar, this is about looking at risks in our system that could affect the delivery of our strategic plans, those big ambitions that we have to improve health and outcomes for our local population. So Laura is going to give us an overview of where we're up to on that. Thank you.
Thank you. As Cathy says, the Board Assurance Framework, or the BAF as it's better known, assists us as a board with our management of our principal risks and looks at the assurances to meeting our objectives. During this last quarter, the focus has been on reviewing the place level assurances. So the Board Assurance Framework has been discussed at each of the 5 place committees over the last few weeks, and it may be that some of our place accountable officers want to share their reflections on those discussions. Each of the board's agenda items have been mapped against the BAF. It's not intended to be an exhaustive mapping, but I think what it does is help to give us assurance that the items we're discussing today do map very well across the BAF, and that we're having a really broad range of discussions. Just ask the board to be mindful of risk appetite as we continue to move through our agenda. It's really important that we keep that in our minds as we discuss things and as we make decisions as a board. I just finally wanted to share the good news that we've just received our internal audit review of the Board Assurance Framework, and we have moved from limited assurance to significant assurance. So that's fantastic news. Really pleased with that. The auditors have concluded that our systems have been strengthened since they looked 12 months ago, and that there is a marked improvement in our arrangements. They've identified a number of opportunities for further improvement, and they've noted that it will require the commitment of all board members to be able to fulfil the BAF's full purpose and potential. The outcomes from that internal audit review were discussed at the audit committee. Again, Jane may want to comment as chair of the committee, and it's reflected in the AAA reports later on the agenda. So as we go into quarter one and each risk is reviewed again, we will of course be mindful of the changing risk landscape really for ICBs and the wider system. When we published the report, we were not aware of some of that. So just to give you assurance that we will be reviewing all of the risks as we move into Q1. Thank you.
Thank you very much, Laura. And as you say, we published our board documentation a week ago, but since then, as people around the table and those watching the meeting appreciate, there have been key national announcements made by government in relation to the NHS, including NHS England being absorbed into Department of Health, and cuts and changes for integrated care boards, including ourselves in the country. And I agree with you then, the Board Assurance Framework needs reviewing in light of that as well. So, colleagues around the table, is there anything that you want to share, either from a place perspective, perhaps, because of the review looking at that? Or Jane, our audit chair, I know wants to come in. And Laura, thank you for sharing that the assurance has improved and our practice has improved in using the Board Assurance Framework. We still are a relatively new organisation, 3 years or so old, and so that is really good that our governance has become much more sophisticated in that 12-month period. Jane, to you.
Yeah, thanks, Cathy. So Jane Madeley, non-exec member and chair of Audit Committee, just to sort of reinforce what Laura said, and also to remind colleagues that although last year we did have a limited assurance for the BAF, when Audit Yorkshire, our internal auditors, looked across their client base, we actually were seen as at the maturer end in terms of how we were using it. So, I think we challenged ourselves in trying to make sure we really embed it throughout the organisation. And I just wanted to comment on, as well as the paper here, as Laura said, in the AAA reports, certainly from the place committees, it's really good to see how there are different references to how the BAF, the evidence that the BAF is now being used much more in terms of determining agendas and discussions at each of the place committees, which is really helpful. Since I've got the mic, I'd just like to ask one question of a colleague when we pick up the broader discussion. So in the appendix, there are a couple of risks that feature under sort of infrastructure. both 2.4 and I think 3.3 in terms of different aspects, in terms of either lack of resources for infrastructure and potential impact in terms of quality of care. And I just was interested to hear maybe from Leeds Place around how they are coping with the fact that obviously the new hospital has been delayed quite significantly in terms of original plans, and just I'd be good to get some assurance as to how they're handling that in terms of obviously that was expected to have significant benefits in the Leeds Place, and sort of how that's been mitigated would be really interesting to hear, please. Thank you.
Thank you, Jane. Can I just clarify, when you're talking about infrastructure, do you mean the estates plan particularly? Yeah, which
Yes,
then links in.
Yes, please. Yeah.
Okay. Thank you. I don't know if colleagues may be able to. I'm looking to Adrian on the around the table, as well as Tim in representing Leeds. So we'll come back to you in a moment on that. Rob, would you wanted to go next, then Richard, and then we'll pick up those groups of questions, which also gives time for colleagues to respond on infrastructure and Leeds teaching hospital funding.
Yeah, I'm just going to partly refer to 3.3, which Jane referred, which is about the risk that we don't have the capacity required to deliver our mission. And I'll come on to this in my report in a bit more detail, but the announcement of a requirement for us to reduce our management cost by 50% will have a material impact upon that strategic risk. Obviously, at the time of writing, that wasn't known, but just so that the board is aware of that, and that we will be updating that risk and the mitigations accordingly.
Thanks, Rob. That's really helpful. And we'll go to Richard next, and then if colleagues could let me know about that response on infrastructure and Leeds. Richard.
Thank you, Chair. It's 1.1 about health inequalities, and it's been rated 20, sort of the highest level sort of, that we have in rating for quite some time. And I think it's just to state the obvious, and it reflects the discussion we just had around maternity services and other services as well that we've looked at as a board over a number of months now, that every week there seems to be announcements either locally, nationally, or indeed internationally, which mitigate against, which push this harder into the harder box, sort of, and make it much more challenging to address. And even today, sort of, I think there will be many of our citizens and local residents worried about benefits and changes, and how that will impact them and how that will impact on health inequalities. And we reflected also on the challenges to local government, sort of, around issues around housing, education, sort of many of the real services that are under pressure because of financial pressures that many of our local authorities are under. And I think it's just acknowledging that fact, that this is a really pressured time for many of the people that we try to serve.
Thank you very much, Richard. That is appreciated. So, Tim, would you just come in on that question on Leeds? And I think it would be helpful, perhaps, Adrian, we can come to you after that on just the situation with capital investment, particularly new hospital programme. Tim.
Yeah, thank you. I'll come in. I want to just pick up Richard's point as well, if that's all right. Yes, in terms of Leeds Teaching Hospitals Trust, in some ways they're still working through what some of the implications are. It's very clear that there are both potentially quality impact. The environment is dated. They were starting to withdraw from it already in preparation, and now having to stay longer, much longer than they anticipated. But there's also a significant impact in terms of their ability, well, the amount of money they're having to spend to maintain. And that is one of the real pressures that I think is already reflected in their financial position and will be reflected much more. The second piece, which I think, and Tony may want to comment on this as well, is clearly part of the plan in Leeds was around the innovation centre. And that I know there is work going on between Leeds City Council and LTHT about how they might sort of mitigate some of that in the short term. So it's not going to go away. It is having material consequences on the way the trust operates. But there is work in hand and further work still planned, I know, and both in the trust and at city level. Just in terms of I think one of the things about the health inequalities piece, and I think Richard's point is really important. Again, it comes back to some earlier conversations. There is something about us understanding what we can do. If we think about the maternity piece, however much the world changes, there is something we've done, and we were able to show that around, for example, smoking cessation, that is beyond and sufficiently in our control and influence. And I think we need to think about how we talk about some of these risks in a way that acknowledges those things that are outside our control, but doesn't exclude us from the things that are within our control. And at the moment, I think sometimes they feel a bit general, and we might need to be a bit more specific.
And Tim, this is something you talked about when you first joined our board a number of years ago, is about what's in our influence, what's in our gift, what we can direct, and then what do we need to influence. And it goes back to an early discussion that Victoria was leading us on public health as well. What's our role, say, in housing, for example, or looking at fuel poverty specifically. But that's being specific about what we can do. Adrian, I don't know if there's any comment there on capital. I think for those that are not so familiar with capital funding in the NHS, some of it is within our system, some of it has to be bid for nationally, and Leeds Teaching Hospital's bid for new hospital funding is now confirmed in, I can't remember, is it called the second phase, which is then in 3 years' time, whereas our colleagues at Airedale Hospital have been confirmed with their RAC issues to be in the first phase, and we also acknowledge national funding for other services as well in our system. But Adrian, is there anything to share there?
Yeah, thanks, Chair. So obviously the first thing to know is we do have a capital infrastructure strategy that was signed off by the board a few months ago now. That is something that we regularly look to refresh. It was kind of submitted as a finalised product, but recognising that things are moving in that infrastructure strategy, there was an assumption that the Leeds Trust would kind of happen, and that's now not, so therefore the strategy constantly needs refreshing and updating. So that's kind of the backdrop. We've got a number of specific capital groups as well to review the strategy, to review different elements of the kind of allocation for capital that we get as a system. It is it's very complex as capital in terms of where we get the allocations from. Historically, it's been very light on infrastructure, I have to say, other than the sort of new hospital programme. There's been a few national specific programmes for certain things that we've benefited from in West Yorkshire, but it has largely been based on historical depreciation, backlog maintenance sort of things. So it's mostly been about repairs, replacements, all that sort of stuff, rather than the more strategic, bigger pieces. With the exclusion of Leeds build for the next few years, certainly anyway, what that has probably meant, if you look at the infrastructure strategy and the plans for backlog maintenance for those trusts, there would be an expectation that Leeds probably didn't need quite so much of that. There will now be an expectation that Leeds probably need more of that over the coming years, because areas of their estate that have been now kind of even older and even less serviceable will need sort of more money spending on them. So it becomes a bit of a circular thing. In 25-26, we have had some additional capital allocations, specifically relating to the delivery of constitutional standards. That isn't the kind of thing that would support a big infrastructure thing like this, but it's certainly an additional opportunity for us to make some specific bids for some things that otherwise would have had to go against our operational capital. But as a general thing, it is a very constrained environment. We don't, relative to the size of the system, we don't get a huge amount of capital allocation. So it's something that we kind of keep in regular checks on, I would say.
Thank you very much. And we also note that the outgoing Chief Executive of NHS England, Amanda Pritchard, talked publicly about looking at alternative funding for the NHS as well, which we watch, but also might be a point of influencing for us as well. Okay, and there is something that I think has been talked briefly about today, Adrian, and I know that colleagues working across the ICB and with Combined Authority, including Jennifer Connolly and Fatima Khan-Shah, about how we better align our public estate in working with local authorities and the NHS, and colleagues are looking at in places as well. So I think there is a further need to that. So there's one of my other handovers to you all about looking at one public estate for West Yorkshire. I've got comments to come in from Kim, Tony and then Carol. And I think that's probably then conclusion. So, Kim.
Thank you, Kim Shuttler, VCSE Sector Lead. I just wanted to ask colleagues about 3.1 about the risk that we don't invest resources in a way which priorities community primary prevention programmes that doesn't maximise value for money. I just wondered about the scoring on that. Seems to me quite low, sitting at a 12 and lower than that in some of the places. And I wondered whether what the decision had been about sort of assessing it at that number.
Thank you. I'm looking around the table to see if anyone can give a specific answer, and if they can't, Kim, we will come back to you. We will come, Tim. Thank you.
Yeah, I think in some ways this is what was difficult because in some ways it's relative. So are we investing less? Are we spending less than we are in other sectors? No. And if I look back over the I've not done the figures for this last year, but the 5 years previously, actually the level of community investment percentage-wise was the highest in the community compared with mental health and acute trusts. So in that sense, I think you can make that case. And then clearly by the time this was filled in, we're also aware of the primary care investment this coming year, which is much higher than every other part of the system. Is it any of it enough? I think that's a different conversation, but in relative terms, that's why I would not rate this as low as you might think. But there remains lots of challenge. I don't like 12s, let alone 16s.
Thank you, Kim, for that question. So when we go to Tony, then Carol.
Yeah, just to comment really on the LGI and Leeds and the impact. It's fair to say the LGI new build obviously was the centrepiece of the innovation arc in the heart of Leeds, and indeed the innovation village, which is sort of the more focused piece within the arc. Those plans are going ahead. There's been a series of conversations, as you might imagine, with planning, with both Leeds University, Leeds Beckett University, and indeed with the combined authority. So just as this is a public meeting, it is really important to emphasise that those plans are to some degree on track, albeit the challenge obviously with the delay is that some of the decisions around businesses inevitably have been delayed, and some of the contracting decisions, but those are things that are being worked through in partnership. And I guess just a general comment is all these decisions, I guess, that are made centrally just demonstrate the interconnectability of all our systems, and why in a really difficult period we actually need more partnership working, not less, and not a retreat to silo.
Tony, that's very powerful. Thank you very much. And just to note around the table, it's just because you mentioned the University of Leeds, we have two colleagues here whose day jobs are with the University of Leeds, Jane Madeley and AC as well, but there is no direct conflict of interest there, so I think I've covered that. Thank you. Carol?
Just a brief comment. First of all, just by way of assurance, Laura's team have been, coming along to speak to our committees as the BAF has been redeveloped, and that's been really helpful. But I think I just wanted to go back to the estate comment, because we went straight to acute development, didn't we, in that conversation? I suspect a lot of while we're filling this in place, will be higher than our target because of the challenges around primary care estate, not just in terms of availability for new buildings, but how tricky it can be sometimes to maximise flexibilities using others' estate because of the knock-on financial consequences of that. So I think that might be driving some of it. And just a quick scan of the narrative suggests that that's been what a few of us have had in mind.
Okay, so we need to align that then with our work on integrated neighbourhood teams particularly then, don't we? Okay, I can see colleagues nodding there who are involved in the Transformation Committee. Is there anything else on board assurance framework at all? But thank you for that discussion, because we've moved on from what does it look like and how does it work and how do we fill it into, is this useful to us and is this prompting the right kind of questions? Thank you. Something I just wanted to note down, and it came out of the meeting in London for chairs and chief execs in the NHS with NHS England last week about use of resources reviews, which some of you may be familiar with if you've been in provider trusts, and that coming back in. You can see that aligning with the theme and drive for greater productivity in the NHS as well. I suppose I just want to put on record that Laura and I have worked for a good while now in making sure that our board aligns with the Care Quality Commission's well-led framework, and in that links the use of resources. But I'd also advise as the board that might be something that have reporting on in future as well. Okay, thank you very much. So, okay, thank you, Laura. The next report is my chair's report. Again, this links with well-led, and it's something that Laura and I work on together to make sure that we're evidencing our variety of things that are going on in the system that the ICB is involved in, and you can see their updates on how we're working with our Integrated Care Partnership Board, which is chaired by Councillor Tim Swift, our work with the Combined Authority and Mayor Braben. And also something that I've wanted to have as a theme in my board reports is about how we're doing our work around involvement with local citizens. And there is a mention there of our continued work on the 10-year plan. Thank you to our colleague Paul Hemingway and the ICB, with many colleagues around this table, including Voluntary Sector, Health Watch, West Yorkshire Voice, in going out and doing a true consultation and engagement on the 10-year plan to feed into the national plans, but also to make sure that we're capturing that information for us in West Yorkshire. I understand tens of thousands of people have responded, and the team have particularly used a variety of different channels and platforms to bring in different responses, which has been really helpful. And you as board members and our partnership board will have that, and I hope that's useful intelligence to you to take forward as well. That links with the continuation of people at the heart of decision making. It's something we set up from the start when we put this board together back in 2022. Nadra Mirza, our non-exec, who particularly has a remit for citizens and future generations, will now work with Paul Hemingway, Health Watch. We want to invite Fatima into this work as well to make sure that this board is being informed by citizens and their views, which is what the Health Watch report was all about this morning in coming into that focus on report. But we know we can do even more and do better. And I've invited Nadra and Hannah, representing Health Watch, to bring a report to the September board, looking all the way back to the recommendations from September 2022 on are we delivering that as a board and what more can we do together. I've said our board development session will take place in April with a number of different things, reflecting on the focus on session, our new digital strategy, and a key area for us in looking at our transformation priorities for 25-26. And please don't think this is another thing we've got to do. It all ties in with our 10 big ambitions, the 3 big shifts with government, and the key work we want to do together. So I just wanted to briefly ask Ian to talk about those transformation priorities for the new financial year, which will be the board's focus on topics over the next 4 meetings. So Ian.
Yeah, thanks, Cathy. So I think the approach we're trying to take to this for 25-26 is to say what are the big things that we need to do differently over the medium term to help ensure the system can deliver the best quality services for people as well as being financially viable. And so the 3 categories that we've described on paragraph 2.5 set those out. So there's a chunk of work led by the provider collaboratives around ensuring that hospital services are as efficient and as effective as possible. There's a second chunk led by places. We've talked about integrated neighbourhood teams and integrated neighbourhood health a lot, around building, with real pace and scale, models of integrated neighbourhood health care. The national guidance on this, I think, is quite helpful and sets a direction in terms of the 6 core components of integrated neighbourhood healthcare. And then the third chunk is really pushing the work that we've started with the Combined Authority around the relationship between health and good work. We know that good work can improve health. We know that if you're healthy, you're more likely to be able to enter into the labour market and get good work. We're fortunate this is one of the few areas where we've been backed by additional resource from government, and we really want to maximise the impact of that in terms of supporting people to stay well in work and getting people back into work. So it's 3 significant programmes of work that we think will make a big difference over the medium term. The next conversation that we need to get into is how we kind of align our capacity towards these things and how we're brave in terms of the things that we stop doing so we can build capacity to get behind these things. That's a conversation that's ongoing, and obviously in the context of the announcements last week that's going to be even more challenging, but this is work that will still need to be done, and it's work that we think is really important in terms of supporting sustainability in the medium term.
Thank you very much, Ian, and that will align with the planning guidance for the NHS as well as what we want to achieve together. So thank you for that. Also, just as you know, the annual governance review is happening. Thank you to Laura and Amy and other colleagues for working on that. If you haven't filled in your survey yet, please can you, because it really helps us improve our governance. Also, I've got a variety of people who are leaving, retiring, and then also new people who are coming into the system. So Carol, as we said, is retiring in a matter of days, and thank you for her leadership in Kirklees. We also have Selina Douglas moving on to a new leadership role in London, moving on from Leeds Community Healthcare. Lem Richards at Mid Yorkshire Teaching Trust is retiring, and we're going to be welcoming back to the system Brent Kilmurray, who used to be at Bradford District Care, coming from the North East to come and be the chief exec there. We also have Chair recruitment taking place at the moment for Airedale Trust and for Leeds Teaching Hospital as a successor to Dame Linda Pollard. And I'm sure as a board we want to particularly thank Dame Linda for her contributions to the NHS and the system over many years. And then also I'm leaving to move on to a new role with Cheshire and Merseyside ICB to become their new Chief Exec in June. And it's at this point I wanted to hand to Jane, who was going to give a very brief update on the process to find your next ICB chair.
Thank you, Cathy. Yes, so I think in paragraph 7.5 of Cathy's report, it explains that in my role as Senior Independent Director, I'm working with Kate as Director of People and Laura, Director of Corporate Affairs, liaising with the NHS nationally, who are leading on the process in terms of appointment of a new chair for West Yorkshire ICB. And ultimately, the final appointment will need approval by the Secretary of State. We have been working with them over the last few weeks and getting their agreement to the process and timeline that we are working to. We appointed Gatenby Sanderson a couple of weeks ago to support us in the process in terms of the recruitment, and we're expecting the vacancy to go live this week, having received approval from NHS England. In terms of timeline, then, we are hoping to have shortlisted candidates go through stakeholder panels and an interview panel that should be held in the week commencing the 12th of May. So that all seems quite prompt. That will head towards a report going to NHS's National People and Remuneration Committee. We're targeting the meeting of the 12th of June. Following that, the next steps of the process will be going up to the NHS England Chief Executive for approval and onwards to Secretary of State. I think we have concerns that that might take a little bit longer than the front end of the process. And therefore, whilst Cathy is leaving us sadly at the end of May, more to be said, I'm sure, on that point later. But in terms of, therefore, from that point onwards, the recent advice in terms of discussion with NHS England is that we should be looking as a board to have an acting chair arrangement for the period from the end of May. And that is based on sort of quite recent conversations. So we are working through with NHS what that would look like and how we would arrange that within the organisation, and we can update as that becomes clearer and as we work through that. So not a lot more to say on that at this point, but that's the route that we'll be looking to whilst we bridge the gap from Cathy's departure to a new permanent chair appointment. Thank you.
Thank you, Jane. That's really helpful for colleagues around the table, and we'll share that across the system. And thanks for your involvement. You usually just do my appraisal. There's a lot more to do this time, isn't there? So thank you for your support. Colleagues, I'm around for a few more months, as Jane shared, but thank you so much for your support and working so well together. Whether you're new to this board or you've been around for a few years, thank you so much for bringing the ICB together, supporting myself and Rob in this. It's been a privilege to work in West Yorkshire. But I don't think I need to make a big leaving speech now because I've got a few more months to go. But this is my last board meeting in public today. And thank you so much for the opportunity to be part of this system. And I look forward to seeing you all at the Partnership Board in April and other gatherings we'll be having, including our board development session. Thank you. The other person to share with you is a new person coming onto the board, is Ed Whiting, who is the new Chief Exec of Leeds City Council. He has now gone through an appointment process as in line with our constitution, and he will be our new partner board member for local authorities starting from next month. So thanks, Laura, for that process. Thanks to those of you who have supported that process as well. And we look forward to welcoming Ed to join this board from next month. My last point on my report, I just wanted to refer back to Fatima. Now, Fatima, you've already talked about the equity and strategy that came together and was shared with the Partnership Board, but there are specific asks to all boards in the system, particularly NHS boards, which includes ourselves. And I don't know if there's anything you just want to share with the board and how we respond to the new strategy on equity and fairness.
Yes, so a reminder letter I think went out last week to organisations to respond. I think we've set the deadline for the end of this month, and obviously there's an offer of support for those that have got any questions. We're really mindful that there are 10 strategic objectives, but that the recommendations to the organisations of the partnership is just to focus on 3. So please don't think you have to do all 10. I know I'm someone who's quite onerous on tasks, but I'm very mindful that we're all very busy. So 3 is the ask, and if you need any help, you know where we are.
Thank you very much, Fatima. That's great. Are there any questions at all on what we've shared, what I've shared, Fatima's updated on, or Ian or Jane? Fatima.
I was just going to say, do you want to talk a little bit about the work and health launch?
Yes, please. That would be helpful. Maybe we set a follow-up afterwards, just to the time constraint we have today.
Really mindful that I've got to leave imminently, so I'm going to do a quick elevator pitch, which starts with the hashtag good work equals good health. We're all going to get T-shirts saying that, aren't we, Ian? One of the really important, I think, and very impactful examples of joint working with the combined authority is the joint leadership that has set up this programme of work. It's been led by Jen Connolly, which is one of the shared appointees, myself, and of course Sarah Smith. It has been built on a significant engagement and co-production with a number of different stakeholders, including our VCSE colleagues, people within our communities, and of course people across this table and your organisations. And it's got 5 areas of particular focus with the vision that we will be the best place to live and work by 2040. The feedback of focus is about the importance of having integrated oversight across the systems. That includes the ICB, combined authorities, the Department of Work and Pensions, as well as the local authorities. A key element, and the reason why I am leaving, is to work with small, medium-sized enterprises to ensure that they've got the skills and capabilities to support our staff to remain in work that have long-term conditions or disabilities, but more importantly, to progress as well. So we're creating the most innovative and diverse workplaces in West Yorkshire. Part of that will require us to think about what incentives we need to support more people into work, but more importantly, really supporting our voluntary community, social enterprise sector colleagues with the holistic support that some people might need with that in mind. And a really important element as well is the development of networks. So there are a number of subgroups sitting underneath the programme of work, and they're really very much focusing on peer learning, resilience and training. So I'm going to stop there, Cathy, because I'm mindful that you want me to shut up and I need to leave imminently, but I'm happy to take questions or circulate an update if helpful.
Thank you. I think circulating an update would be really helpful, particularly for place accountable officers to take into their discussions, which align fully with everything else we're working on at the moment in trying to bring services and care together to support people in their communities and in their homes. So thank you for that. And it was a great opportunity to join Mayor Braben last week to talk about this in front of a real mix of people from the voluntary sector, Department of Work and Pensions, the Combined Authority, NHS England, the NHS. And there was a great example from South West Yorkshire Trust on how they've been working on creative health, which had helped to improve results in care in wards at South West Yorkshire Partnership, which was a really great thing to hear, including being BMJ published as well. So that was the importance of creative health in that service, which is brilliant. Fatima, thank you very much for all you're doing, and we'll follow up on the work and health plan. So, Rob, we'll hand over to you now. We're on item 17, which is Rob's Chief Exec report.
Thanks, Fatima, for that, and enjoy the rest of the day. Just wanted to say, take the report as read, but I'm going to emphasise some points. Probably start with the fact this is Cathy's last meeting in public, and I do pass on my thanks in the paper, and I know on behalf of the rest of the board, would like to thank Cathy for her leadership of the organisation and of this board. I always think that she's very fiercely, committed to health inequalities, unfailingly positive and passionate about what we do, a massive advocate for everything we do, and courageous. There isn't another system in the country that still gives all of the money to places, despite, what the national move has been. Doesn't mind talking about things which may be contentious but highly relevant to the work that we do, and influential, continuously involved in conversations publicly and not publicly on things that really matter. And I'd like to give my personal thanks to Cathy for all the support she's given me as the Chief Executive. It's been really fantastic, thank you. When we went out to recruit a Chief Executive previously, I wanted us to make sure that we didn't have... Sorry, Chair. Well, you've become a Chief Executive, haven't you? Yeah. When we were out to recruit a Chief Executive Chair, I said we didn't want one of the usual suspects necessarily. We wanted a broad field. We wanted to see where the talent comes from. And I'm glad that we ended up with not one of the usual suspects. We ended up with someone who has been brilliant. When we recruit somebody else, or NHS England does, we want to make sure that they pick up the learning that we've had in terms of inclusive recruitment, You know, this is the chair that produced a video and guide for everybody to how to get a job in the NHS as a non-executive. So let's hope that that is spread around so that we get somebody who can do the job, because it's a tough one. So I think the board should thank Cathy in the usual way, really. I think since I wrote the report, just a couple of things have happened, haven't they? So at this point, you know, the chief exec of NHS England had announced she was stepping down, but subsequently, the deputy chief exec, director of finance, the director of system reform, and the chief operating officer have all stood down as well. And I think I would like to thank them for their leadership nationally. And I thought that Amanda Pritchard, as chief exec of the NHS, had always set a tone and appreciation of the fact that systems and system working was incredibly important. And we've hosted her here a few times, and it's always been a good and positive and challenging sort of conversation done in the right way. So I think we should thank Amanda and the senior team. Clearly, we've got a new set of people involved and some things have happened. So I just wanted to alight on some of those. What do we know about what's happening at the moment in the NHS? Well, the first thing we know is that there's a new chair of NHS England as well, Penny Dash, Dr. Penny Dash, who's previously the chair of North West London Integrated Care Board, and a doctor by profession, but has also worked in central government and for a range of other organisations. And she's been outlining that, you know, we really do need to focus on all aspects of quality. Isn't that great that the first thing that somebody says is we should be guided and driven by quality in a conversation that's often dominated by money? And when she says quality, she talks about, you know, our service is effective, is the experience of the individual right, and are we seeing safe services everywhere for everybody? So focus on quality, focus on productivity, because productivity isn't where it used to be, and the services aren't designed to deliver the best outcomes for the inputs that we put in, and a focus on system. Now, I think we would all get behind, you know, a focus on quality, using the resources we have wisely to deliver the biggest impact. That's one of our 3 missions, isn't it? And making sure that we have an effective system for delivery. Again, one of our jobs. You know, the 5 focuses of ICB, part of it is partnership development. In that context, then, there have been some changes announced quite rapidly last week, and quite unexpectedly. So we'd already heard that there was an expectation that there was too much, because of duplication between the Department of Health and Social Care and NHS England, there needed to be a reduction of 50% in the costs of work undertaken by DHSC and NHS England. What we heard last week was that NHS England will be absorbed into the DHSC and formally abolished. So NHS England was created in 2012, and prior to that, those arrangements were similar. So there was an NHS executive within the Department of Health and Social Care, which was separate within the organisation, tasked with operational delivery. What we heard also last week was that there would be a 50% reduction in management costs within ICBs. And, you know, I was made aware of that on Wednesday. It was in the HSJ on Wednesday, and it was formally announced on Thursday. Now, I will say that it's deeply regrettable, isn't it, that staff found out in the media. And the following day, staff found out in NHS England that their organisation had been abolished, often in the media. And that's not something that we would potentially want ever to happen. I wouldn't ever want that to happen. And it's regrettable that people did find it out that way. But we will face a 50% reduction in management costs, as will providers will be required to reduce the growth in corporate costs by 50%. And there'll be a 50% reduction in provider collaborative operational delivery networks and other non-clinical facing corporate costs. So providers seeing a reduction in the growth in the management costs that they've had, us seeing a 50% reduction in our management costs, and NHS England and DHSC seeing a 50% reduction in their costs. In saying all of that and the abolition of NHS England, we've got to recognise that that's not going to happen legally for a couple of years. I don't think that Monitor and the Trust Development Authority were formally abolished for years either. But NHS Improvement existed for ages, and then NHS England before they became part of that. So there's some work to do on those things. The expectation is, at the moment, those reductions are delivered by Q3, which takes some doing. What do we know over and above that? Not very much at this point. Upon hearing about that, we immediately briefed all our staff. So I found out on 5:30 on Wednesday. We sent a note out on Thursday morning, given it in the media. There was a meeting in London at 10:20 till 12:30. At 1 o'clock, I did a briefing for all staff. Almost 900 staff turned up for that briefing, and I told them what we knew. We've subsequently agreed that we also then sent out a note, and we sent out a note to all partners. We subsequently agreed that every Tuesday we'll do an update for staff. I just signed mine off in the break that we've had here. And we will meet every Thursday as an executive to go through how we are managing these changes together and how we ensure that we do it in a way which is thoughtful and constructive and takes every opportunity that we can to make sure that we're reducing duplication and doing things that have impact. We've also made sure that staff get support for their well-being from their colleagues, and it's been really great to see drop-in sessions set up by people around this table. So Therese and I sat with Bradford District and Craven staff yesterday, hearing their thoughts and their feelings about matters. I know that the staff networks have also put things in place too, to drop in and have a conversation with colleagues similar to you about how people are feeling. And it's been really positive to see the pragmatism and the constructive views of staff and partners about, okay, what we're going to do then. I don't think people necessarily, they are feeling it. They're also very much thinking about how do we make the change happen then, and how do we do it in the best possible way, which is hugely to their credit. I think it'd be very easy for us to get sucked into what's happening nationally and what all of this means and what else might happen. But we need to stick to the facts. And we know what the facts are. People face massive inequalities in West Yorkshire. We need to join up care. We need to make sure that we use our resources wisely. And we need to stick to the 4 purposes of ICS. And we need to do that together. And as we heard this morning, when we do, we can make a real difference. So as I say in my report, it'd be very easy to get distracted by all the national stuff. Since I wrote that, we've also got a significant impact upon our business, and we have to collectively look at how we're managing that. So we are taking stock of how we do that. And we're doing that through the executive, through those weekly meetings, and we'll be briefing partners in writing every Tuesday about how things are going, what we know, and what the next steps are. The other thing we should also recognise is that those reductions, when we say NHS England, corporate costs in providers, our management cost reduces by 50%, you might forget that this is geographically distributed. And NHS England and Department of Health are geographically distributed across England with main centres in Leeds and London. So this will disproportionately affect our population in Leeds and across West Yorkshire, because the scale of the reductions is significant. And that's something we need to keep in view. And I know Tim and Tony and partners in Leeds, Sarah and others are very aware of that. As a board, it's pretty clear to us now is the time for us to keep that focus on the plans for next year. We've had a conversation about that and where we've got to with them. How we then deliver those plans and how we prioritise our work. And again, we'll be doing some work and some thinking as an executive to try and take stock, think about the design issues, think about the work that Anthony's been doing on places and West Yorkshire, and maintaining our focus on our values and behaviours so that we can be successful. There is a big job for us to do, and there's a job for the board to oversee. And I think our history tells us that we can do it, and we can do it successfully, so we should. I think that's all I wanted to say. The rest of the report, I think, speaks for itself.
Rob, thank you so much. And we'll start noting down people who want to come in and comment. For anyone watching this meeting in person or on live stream or record afterwards, to let you know, we had a board briefing at the start of today. We met early to reflect on the news that was shared with us. And we've got a number of key points that we discussed this morning around understanding the timeline, particularly our colleague Kate Sims, as Director of People for the ICB, is working with ICB colleagues across the country, as well as within the system, making sure that we're holding on to our system values and we're treating our colleagues with understanding, care and compassion, and this is about people, not processes. We had a series of questions that we wanted to ask further clarification on from NHS England. We recognise the laser-like focus that has been requested of us and the provider trust within the NHS. And we also note that Mayor Braben, along with the leader of Leeds City Council, particularly highlighted that issue for Leeds in light of the announcements as well. And we discussed about holding on to our partnership working, which Rob has just talked about, as well as the planning guidance for the NHS for 25-26 still stands. And that includes a strive for greater productivity, as well as the foundations of integrated neighbourhood healthcare. And also our strategic plans and joint forward plans still stand, as well as the overall government's vision of the three big shifts in health and care. So please, for anyone watching the meeting, there has been a very robust discussion, and I hope you understand and respect the fact that as we are absorbing and taking on board the news, we needed a private briefing session this morning, but as Rob says, we will be communicating regularly and openly as we receive more information. Richard, did you want to come in there? Would you introduce yourself, Richard?
Yes, I'm Richard Vautry, a GP in Leeds and Primary Medical Services representative on the board. First, I just want to thank you, Cathy, for all that you have done as chair. You've certainly made me welcome as a board member, and I'm sure that's the case for all board members as well. You've had a massive impact, not just on the board, but on the people of Leeds and the people of West Yorkshire. I just want to thank you for all you do and wish you all the very best in your new endeavours. And thank you too to Rob for the work you've been doing over the last few days in really unsettling times, for the rapid way you've responded to that, to ground things in reality and reminders of our priorities. And I think that's really important as well. And I think you've already touched on something I did want to mention is, as GPs, particularly in Leeds and surrounding areas, we will see a lot of healthcare workers over the next few days and weeks and months who are very worried about their future, unsettled by the future. We need to remember that we haven't been a board for very long, and yet we've already gone through a significant management cut, and that's unsettled our staff. They've only just gone through that and now have to face this again. So there will be huge uncertainty, and I hope as a board, and through you, we can pass on our best wishes to our staff, that we say that we have their backs and we will try and do what we best we can to support them, to enable them to support our patients and our residents and wider staff as well, because I think we do recognise the huge uncertainty and worries that they will have. Yeah.
Richard, thank you very much. That's good of you. And also this gives me a point to remind colleagues, because we know there's a lot of members of staff who watch our board meetings live on live broadcast or on record, the reminder of the offer of the West Yorkshire Health and Wellbeing Hub, which is there for all staff in any sector working in health and care, and that is available for support. Thank you, Richard. I think, yes, again, I reiterate my thanks to staff who've worked with Rob to get those staff briefings and communications up as well. I think that's really helpful. helpful. And just a reminder from our board briefing this morning, as a unitary board, this is a requirement for us to oversee these cuts in running costs and programmes for the ICB, as all 42 ICBs in the country are being asked to do. Are there any other comments or questions? Mel, would you introduce yourself?
Hi everyone, I'm Mel Brown, I'm the place lead for Wakefield District. I just wanted to share, following Rob's briefing, I did a local briefing at Wakefield, and obviously a lot of staff are unsettled and feeling anxious, but one of the things that people asked me to share was that they do feel that they're being treated with kindness and understanding, and they did appreciate that we're sharing, and we've got a communications mechanism now with weekly briefings every week in place so that they know that they'll be able to access information. And I just want to reiterate something Rob said. Actually, I had an hour's discussion with staff, but 40 minutes of that was what can we put together to support each other. You know, I've got this particular skill. I'll do some lunch and learn sessions on, meditation. I could do some things on therapy services because we had some people with those sort of skills. So it was just really compassionate to see how people are trying to support each other, even though they're processing it themselves. So I just wanted to share that.
Thank you, Mel. That's really helpful. And I know all our place leads across our 5 places have been engaging with their teams as well. I think we also need to recognise that there is a ripple effect into working with other colleagues across the system, and we also recognise, and it's very clearly in the risk register, Kim in representing the voluntary community and social enterprise sector, the instability there for the sector, as well as the issues that local government are facing at the moment as well, which comes back to Tony's point earlier on, which is the importance of partnership working at this time and working collectively. Are there any other comments or questions at all, and anything that you might need as a board member as we go through this rather fast-paced decision-making and changes? I think we can commit together to sharing what we know. That's what we've done over the last few working days. And you all have roles that you play locally, regionally and nationally as well in different ways, that I think any information that you can share, I encourage everyone to use trusted sources of information to share, and I think it all enables us to work effectively together. Rob, is there anything else?
Just to make sure that we, we've got to keep an eye. I always say, we've got to keep an eye on what we're doing today. Brendan and I were joking about it's not really the end of the winter yet, and we need safe services every day. We need to make sure we're planning for next year, and we need to make sure we've got a secure medium term. And in all of that, I think we've always been pretty good at being organisationally agnostic. The primacy of place is about the citizen. The citizen comes first, the person comes first, and the organisations are there to serve. We're all here to serve. So we're trying to make sure that we have the best range. We're not going to fight for organisational form. What we're going to do is make sure we have the right functions and we're delivering the right work to improve outcomes for local people. And there's much to like, I think, about a focus on quality and productivity and getting the systems right. There's much to like about decluttering and the frustrations we felt and our provider colleagues around the table have felt, and our third sector and primary care and other colleagues have felt around that we really want to empower people themselves to look after themselves, and then people as close to those as possible to be working in integrated services which join up around their mental, physical and social needs. We want all of that to happen. Mm-hmm. And this disruption, I think we need to shape to be in that position. And I think some of it's designed for that to happen. That's the intention around this, and the intention is probably a good one. The bumpiness and the way that that's felt by a lot of people, we're going to have to deal with. But let's not, I think somebody else said it around the table, didn't they? Let's not, Tony, I think it was earlier, let's not retrench into an institution. It's time to sort of continue to work together to make sure that we're doing our best for local people.
Great. Thank you very much, Rob. And again, thank you for your leadership on this change at this time. Okay. Colleagues, we'll keep in touch, I think. I think that's the most important thing at the moment, and keep communicating. We'll move on now to items 18 and 19, and as we do usually, we'll take these all together. So what you have is 18A, our system performance report, which Lou and Adrian are going to do a short summary of in a minute. We then have Laura talking to us about our corporate risk registers, so those immediate risks in the system, unlike our strategic risks, which are on our board assurance framework. And then in item 19, you have AAA reports. So these are committees within our ICB governance arrangements who are highlighting things they are assured on and things they would like to alert the board on. And you can see there are a definite theme throughout those reports around financial sustainability, looking at productivity and efficiency, and looking at landing the current financial year budget as well as preparing for the new financial year from the 1st of April. And there are other themes that come from that as well in looking at specific things by places, which I'll come to in a moment. So I'll hand to Lou and Adrian first, then to Laura, and then we'll take the item 18 and 19 all together. Lou, do you want to start us off? Thank you. Would you introduce yourself?
Yes.
Just helpful for people watching the meeting.
Thank you, Cathy. So I'm Lou Auger. I'm the Interim Director for Planning and Performance. And what you've got in front of you is the performance dashboard. It's got a range of topics and it helps to signpost, I think, to areas of concern and interest. And it links across to a whole host of work that's been led through our programmes. For this pack, we've added an extra slide, slide 5, which we will expand on, and it starts to introduce the new targets that are coming in as part of the current planning round going into 25-26. And then just to remind ourselves that whilst these are numbers in a pack, we're actually linking pieces of work around health inequalities to the different metrics that we've got. So there's sort of a piece of work to do that. A few of the highlights then, so I'm just going to pick out a few. In terms of improving access to psychological therapies, we continue to achieve the standard for recovery rates, which is great, and the talking therapies performance has improved since the previous quarter. In terms of dentistry, we're improving access to dentistry through maximising and increasing the units of dental activity and through our 14.5 million investment plan. So the latest data shows that we're performing above the national average by 5% for both adults and children, which I know that there's more work to do, but that's really, really good progress. For the cancer standards, we've continued to achieve the 28-day faster diagnosis standard, and we've been increasing our performance on the 62-day to treatment standard and reducing the gap to the national targets. And the last item that I wanted to pull out was around the diagnostics. So we're performing well against the diagnostic waiting time standard, which sees an increased number of people receiving a diagnostic test within 6 weeks, which is the standard that's set nationally. And that you can see where we are in the sort of benchmarking, so the latest data showing that we've ranked first out of 42 ICBs around that particular metric. On slide 82, we move to the finance section, so I'll just ask Adrian to introduce himself and to pick that up. Thank you.
Hi, thanks everyone. So I'm Adrian North, the Deputy Director of Finance for the ICB. So just talking through there's a few slides in the pack overall, just to give you some of the key headlines for them. So at the end of month 10, we were saying we had a year-to-date position across the ICB, which was a deficit of £55 million. That was against a planned deficit of 16 million, so we were about £39 million off plan overall. Despite the size of some of those numbers, the intention and the expectation was that we'd still deliver in line with our forecast, notwithstanding a whole load of work to get to that position and working across the different collaboratives and across the ICB to get that done. There was significant risk identified at month 10, so the paper talks about a potential change in forecast at month 11. I can report now that we're not going to be changing the forecast at month 11, we're going to be maintaining the forecast at a break-even position. That is, as I say, following the work that we've been doing, working with providers, working with the ICB, trying to identify anything and everything we can kind of do to mitigate the position. It's all been through the various committees, that the approach that we've been taking has been ratified by the various committees. So I think there's a clear understanding about the approach that we've taken to get there. As at month 11, we're just about to report month 11, there's nothing that I'm seeing at month 11 that would indicate anything different to that, so we are still on track to deliver that position at the end of month 11. Just a couple of other bits and pieces that are in the pack. So there's a reference to efficiencies in the pack. Talks about under delivery of efficiencies. That is one of the drivers of the position that we find ourselves in. So the adverse variance that are reported is partly to do with the fact that if you just look at individual efficiencies described at the start of the year, we're not quite there with all of those. That said, there are a number of mitigations clearly to get us back to our break-even position. And they're more than offsetting the under delivery on the specific efficiencies listed at the start of the financial year. And then just a couple of other points to note. We are anticipating that we will deliver our mental health investment standard, which is great. And in terms of our agency spend at the start of the year, for the last couple of years actually, NHS England have set a specific agency target for the system, and we are significantly below that for 2024-25. We're looking at we're going to be about £27 million under our ceiling overall. So yeah, just keeping our finger on the pulse to make sure we can deliver that position by the end of month 12, that break-even position.
Thank you very much. And Laura, to you on the corporate risk register.
Thank you. So today marks the conclusion of the final risk cycle for this financial year, and we've concluded with 56 risks for review. I did just want to flag that, so there's 54 open risks, that compares with 43 at this point last year. However, I would also flag that the average score has actually reduced year on year, so I wouldn't just look at numbers and think that means that we've got an increasing level of risk. It's worth looking at the full profile of those risks. There are 6 new ones that have been added during this risk cycle. As always, I'd want to draw your attention to those. They have all been looked at in much more detail in either the Quality Committee or the Finance, Investment and Performance Committee. One of those new risks is at a high level, and that relates to children's hospice services. We have 3 risks that have increased in score. One relating to VCSE services has moved from a 16 to a 20, so that means that it's moved from a high level risk to a critical level risk. You will see within the report there is some narrative showing the discussion that happened through executive management team and committees in relation to that risk. And there are also 2 others that have escalated into the high risk category, so one relates to elective care and one relates to a cancer performance risk. Having said that, there are also risks that are reducing in score. In fact, there's 7 that have reduced this cycle. 2 have reduced from being at a critical level, one relating to infrastructure investment and one relating to RAC at Airedale. The rationale for all the changes, whether the risk scores increased or decreased, is contained within the report. That is a new development and hopefully gives you some insight into why risks are changing in terms of score. For assurance, I'd just draw your attention to the high-level risks in places, which you may wish to triangulate again with the AAA reports. They should give you some more insight into the discussions that have taken place on those, and also where we have common risks, which are you would see in 2 or more places. You'll find detail at section 5 and 6 on the discussion that happened at executive management team and at the 2 committees, and again that hopefully provides additional assurance on the scrutiny of those risks. The board has been asked to review the register and also to consider whether there are emerging risks on the horizon which need to be captured, which I'm sure we have talked about a number of those as we've been working our way through the board meeting, and we'll be picking those up as we start the new risk cycle tomorrow. Thank you.
Does anyone around the table have any comments or questions at all on those documents shared, and also we'll come to the AAA reports in a moment, but on those items shared by Lou, Adrian and Laura? Kim?
Thanks. I think it's good to see that the risk has gone up because it reflects the reality of the situation for the VCSE. However, I did want to note at the board that I think it's really, really positive that across West Yorkshire we have collectively agreed to treat our VCSE contracts in the same way as our NHS contracts in terms of the standard uplift. And whilst that's 2.15% and of course isn't the magic bullet in terms of addressing the sustainability challenges that we face in the sector, from speaking to other VCSE colleagues across the country, I certainly don't think that is happening across the board. And I think from a principles perspective, it's really welcomed by the sector because it's a mark in the sand, about a collective agreement across West Yorkshire so that people are all being treated in that way and being treated with parity compared to other NHS providers.
Thank you, Kim. And I just wanted to reiterate here, I suppose it's also to get it down in the action log, that you are very welcome to come and report to the board again, following up on your report from early 2023 on the sustainability of the sector and things that have happened since then, that for the positive, but things that still need to be done, whether that's at place or system level as well. So I'll leave you to discuss that with Ian Holmes and Laura, but you're really welcome to do that for a future board meeting if that's helpful to you in the sector. Thank you. Kate.
Thanks, Cathy. Just to say that obviously I recognise in the last period of organisational change we did have a risk that acknowledged obviously some of the workforce impacts of what Rob just described. Just to flag it's an action for me, I think, Laura, that I will develop a risk that reflects obviously that we will be moving into another period of significant organisational changes as an ICB. So just to note that I'll take that action forward. Thank you.
Any other comments or questions at all? Hannah, and then we'll go to Rob.
Yeah, I just suppose just to reflect from a people's experience perspective, I know we talked about that actually when we did the paper a couple of years ago, Becky Mulby and I, around how do we make the dashboard sort of realistic from a person's experience. So so it would be good to bring that into the review in September, Cathy, around that, I think, because if from a, these are significantly challenging times for the NHS and there is some brilliant work going on, but there is still serious issues around access to dentistry, lack of parity in terms of mental health support, and other issues as well. So there's something just about bringing that to life with these reports, and also the impact of cuts. Being able to articulate what will that mean for people, particularly with a focus on inequalities.
Great. Thank you, Hannah. And that also comes out of Fatima's fairness and equity strategy as well. There's a really clear recommendation if you go through them on how you do this kind of reporting and bring in that lived experience as well. So it reiterates something you've said for a long time, and I think that's why I'm giving you the platform in the coming months working with Fatima as well to make that change, or improvement, should I say. Thank you. I just want to comment, it's great to see the improvement in the diagnostic testing that you just shared. I think that's really welcomed. Rob?
Yeah, I think we need to look at these reports on performance, quality, money, risk as the baseline for the coming financial year, which is what they are. And if we do, I think we owe a huge debt of gratitude to all of the partners around the table for what looks like we'll be able to achieve our financial plan in a year when we've had the quaddemic. That seems like a long time ago now, doesn't it? But it was only a couple of months ago. Affecting services significantly, the resourcing of services and the delivery of services. When we've had ongoing concerns and actions by our primary care colleagues who deliver, such a vital part of everything that we do, and where we've been under significant pressure almost continuously. I think Brendan often says, winter's all year round and escalation beds are always open. So we shouldn't let that pass. If we're going to achieve our financial targets this year, that's down to the sheer hard work of people in every organisation represented around this table, and is a huge example of the difference that we make together. Similarly on performance, I think we've heard about the substantial improvements on dentistry. There's a long way to go. I mean, Hannah's continuous warnings on this are right. We can track improvement. We're still some distance from the ideal. But the rate of improvement and comparative with others, we're in such a good place compared to others. So we do need to keep that improvement going. And all of this puts us in a good place for next year's plan. So let's not let that moment pass by. I know a lot of the conversations have happened in places through FIPSI and elsewhere, so that's why we're not having such a detailed conversation here. But I just did want to thank all the partners around the table for landing the money and for making some substantial improvements in all sectors across the year.
Rob, thank you very much. I reiterate that as well. Thank you. I want to shout out, I wondered if you'd just talk briefly about your plans for the digital strategy. There's a big theme in these risk reports around cybersecurity, digital maturity, assurance around that, that's come through the audit committee, as well as discussions on places. I don't know if you could talk about the risk management as well as the maybe very, very brief update on your plans for the strategy as well.
Thank you, Chair. As part of our digital strategy refresh, we are at the moment, we are just concluding the discovery phase of that. What that includes is that reflecting on the previous strategy from 2022 with the DARZA report, with all the new context within the AI, and then especially the last week's announcements. What is the impact of all these within the context of our digital strategy? So what we did is that we went with the three different parts, but combined all three in one. So one was reflecting on all these things. Plus, we conducted around 110 engagements with individuals and forums to understand about our strengths, about weaknesses, and then what are the ideas, what are the expectations from all across all the stakeholders. Also, we consulted with NHS England and also other ICBs about how they are doing, how they are tackling with the digital part of it within the context of the expectations and then the future. And then the third one was, of course, the industry. So we consulted a lot of engagements with all the technology leaders across the board about what are their roadmaps look like to support our roadmap, and then what we can learn from the industry and then incorporate within our strategic point of view. Based on that, we have now actually concluded the discovery phase of it. Our plan is to submit that in 2 weeks' time to our EMT for their evaluation, and then of course in the next digital board meeting, then we will bring that to the board. One of the areas what we are focusing is that how we can put patient in the center and then enable through digital means throughout this journey. So that is something we are evaluating on how best we can do, what are the gaps in the current system, and then how we can enable our patients and also our staff through the digital literacy program. Of course, there are so many digital parts there, but how we can make sure they know about those things, and then they are educated and they know about how to access those things. So I think enablement and access is primary for us. And then another big area is, of course, all the emerging technologies, the use of AI. And as I mentioned in a couple of hours ago, that we have established the AI steering group, which consists of all the digital, clinical, and non-digital area colleagues to leverage the experiences across, to identify the use cases and also the best practices if one place is doing or one trust is doing, how we can leverage to. Also, the other parameter is how to learn from national and regional level what is happening. We are connected with our regional colleagues, our national colleagues, and we have invited the AI focal persons into our committee so that we can learn about what's already there and then what we can use within the context of West Yorkshire. So as a digital strategy, we are coming up with 6 thematic areas that includes the infrastructure, AI, data, digital workforce, as we have been talking about, digital literacy part of it, and then cybersecurity. So these are the areas we are working.
Shaukat, thank you so much. That's really, really helpful. I know Health Innovation Yorkshire as well have offered to do some exchanges across ICBs to support you. And another thing I leave you on your to-do list as a board before I move on is consideration of the NHS Confederation Digital Boards programme to improve the digital literacy of the people sat around this table as well and help their decision making, which I know you're looking at as well. Yeah. Thank you. I'm just getting that on the to-do list as well. Thank you. Jane, did you want to come in?
Yeah, thanks, Cathy. Just reflecting on the sort of risk register and the reporting, as Rob said, there's a lot there, and we might not appear to spend as much time on it, but we're conscious that there is a lot of that review and scrutiny happens in the subcommittees of the board, including the place committees. I personally find some of the section in the report where it talks about reflections from EMT and from FIPSI and Quality Committee really helpful, because you can kind of evidence and see the discussions that have taken place. We see a little bit in the AAA reports, but I wonder if maybe we can sort of make that a standard piece that we would expect, sort of highlights of those discussions from the place committees to be reflected. I think might be helpful, so we capture similar to what we see from FIPSI and Quality Committee. And then finally, I was just reflecting on discussion recently at Audit Committee. So we received a first annual risk report that's going to be a regular piece going forward that supports us in completing our work around year-end governance, reporting, etc. And within that, one of the recommendations is that from now, from next year, new year coming in, at Audit Risk Committee, we'll be thinking about doing deep dives into some of the risks within the risk register and the BAF, so we can look across some of the risk areas. So that will also be a new way of ensuring that we're giving appropriate time and attention to items within the risk register, even though they might not all get covered here in the board meeting. Thanks.
Okay, thank you, Jane. That's really helpful. That's all part of our good governance and our oversight. Are there any colleagues on the table who particularly want to highlight anything out of the AAA report? Very much recognise the theme across all the committee reporting around financial constraints, that strive for productivity and efficiency savings, and those discussions particularly within local place committees. AC.
Thanks, Kathy. Just want to highlight something because there's one report missing mainly because of a delay in producing that report from myself, because we had an additional transformation committee at the end of February, and for this, I think it will come through the next board in the pack, but we discussed the integrated neighborhood blueprint as well as the UX blueprint among several assurances. So just providing assurance to the board that there was in-depth discussion across both of the blueprints, some suggestions made. It will come back to the next transformation committee and come back to June board for discussion and approval.
I really want to thank everyone who's worked on that urgent and emergency care blueprint, which was a huge amount of work across different organisations and people. I went along to one of their sessions, which really was a can-do problem-solving opportunity. And we also have the integrated neighbourhood team blueprint. It's something we've worked on for 9 months or so now. Very much now aligns with the government's wish for integrated neighbourhood healthcare to be established and the planning guidance from NHS England. So this is all very relevant. And I know place accountable officers have got that blueprint to work with their place committees as well to respond on, and I know each place is then making sure that's tailored in their way. So and that then aligns with the place arrangement review and expectations to be achieved by April 2026. So you see, everything does fit together, which is brilliant. Okay. Are there any other comments then on item 18 or 19 at all? Looking around the table? No? Okay. Well, I think we'll take a break now and then we'll move on to item 20 and responding to the planning guidance. We'll take a 10-minute break now. Thank you to those of you who are observing in person or online at the moment, and we'll just take a quick break now in the meeting. Thank you.